Hi there, my name is Fiona Duncan, and today, along with our peer researcher Gillian Samuel, I will speak about our mapping exercise of community interventions to improve public mental health in adults in England. We've heard from previous talks today in this symposium about what public mental health is, ways in which it can be measured, and some of the previous research which has investigated aspects of it. However, in this talk, we will focus on what is actually happening on the ground. What action is taking place in the community to improve public mental health? As we've also heard today, there's a very wide range of modifiable psychosocial risk factors which have an influence on the mental health and well-being of the population. These include economic disadvantage, debt and financial difficulties, unemployment, social isolation and loneliness, intimate partner violence, sedentary lifestyles, food insecurity, homelessness, and discrimination due to belonging to a minority group. There's emerging evidence that community interventions that tackle such risk factors have the potential to improve resilience, well-being, and mental health outcomes. However, the current evidence base for the effectiveness and cost-effectiveness of community interventions is limited. This means that there is generally little understanding of the underlying mechanisms which may make community interventions effective at improving public mental health. This lack of understanding makes it difficult to know which aspects of an intervention to replicate or which interventions could be successfully delivered on a larger scale. Therefore, to progress the provision of public mental health services and approaches in the community, we need to have better knowledge of what is currently being delivered in local areas. Specifically, we need to identify any promising practice, any learning from existing practice, or gaps in service delivery, and what evidence exists concerning the effect that they have on meeting population needs. This information is important for policymakers and commissioners. This is especially important for the COVID-19 area, as it is anticipated that there will be a greater demand for such services in the coming months and years. Therefore, in light of these evidence gaps, this study aimed to identify the range of community interventions that aim to improve mental health and well-being in 5 diverse areas of England, and describe the model, target population, content, and outcomes of each intervention. So, what did we do? To investigate community interventions in England, we carried out a mapping exercise. This means that we aim to collect and collate as much information as possible about community interventions to improve public mental health being delivered across 5 selected local authority areas of England. The 5 chosen local authority areas were Redcar and Cleveland in the northeast of England, Blackburn with Darwen in the northwest of England, Cambridgeshire and Peterborough in the east of England, Hammersmith and Fulham in Greater London, and Camden and Islington also in London. These areas were chosen as we wanted the mapping exercise to be representative of different areas of England and to include areas that consisted of different compositions of social deprivation, age and ethnic background. The proximity to the research institutions and existence of established contacts and networking was also considered when choosing the areas. So in our mapping exercise, we included all community interventions that aim to improve adult mental health and all well-being. Now, I'm aware that there is some debate regarding how exactly to define a community intervention. Our definition, for the purposes of this study, of a community intervention was any non-clinical programme, service or policy that explicitly aimed to promote the mental health and well-being of residents. We also only included interventions that were available to local residents between July 2019 and May 2020. We excluded from the mapping exercise any interventions which could be described as clinical mental health interventions and any interventions which were exclusively aimed at children or adolescents. We aim to collect a wide range of information about each intervention, including the type of intervention, its aims and objectives, its target population, its intended primary and secondary outcomes, the content of the intervention, the geographical area of delivery, how the intervention is delivered and by who, how it is funded and for how long, and whether the intervention had been evaluated. The data collection process involved several stages. Firstly, the websites of local authorities, NHS clinical commissioning groups and relevant third sector organisations were searched for policy documents, annual reports and guides signposting local residents to interventions in the area. Then, key informants in each of the 5 selected areas were contacted to provide further information about each intervention and direct the research team to other relevant organisations in the area. Key informants included people like public health practitioners, commissioners, programme managers, local link workers, community navigators and representatives from local voluntary sector organisations. And the data collection process from these individuals involved multiple methods, including by phone, by email, face-to-face meetings, the use of an online questionnaire, attending local mental health committees, and analysis of provided documents. Peer researchers also contributed to data collection and intervention identification through their own knowledge or by contacting key informants themselves. Researchers continued to search using this process until they had an exhaustive list of interventions in the area that they were looking in. So, what were our key findings? So, how many community interventions did we identify? Across all 5 sites, we identified 407 community interventions that met our inclusion criteria. 62 of them were in Redcar and Cleveland. We identified 99 in Blackburn with Darwin, identified 106 in Cambridgeshire and Peterborough, 75 in Hammersmith and Fulham, and 65 in Camden and Islington. These interventions were mostly delivered by the local authority, third sector, NHS clinical commissioning groups and community groups, either independently or in partnership with each other. So we were able to classify the 407 identified interventions into 15 different categories depending on what risk factor or protective factor the intervention aimed to address. The most common risk factor that interventions targeted was social isolation and loneliness. 38.3% of all interventions identified across all 5 areas aimed to reduce social isolation and loneliness. The next most common risk factor was financial stress, followed by mental health stigma, knowledge and awareness, then stigma, discrimination and marginalisation due to ethnicity and migration status, then mood, confidence and self-esteem, and then community safety and cohesion. The least most common risk factors identified were physical activity and other health behaviours, job security and unemployment, access to health and social services, family relationships and parenting, gender-based violence, caring responsibilities, bereavement, stigma, marginalisation and discrimination towards LGBT, and finally food insecurity. We were also able to classify the identified interventions into 12 different types. The most common type of intervention that identified could be described as a social activities and/or befriending intervention. 44.7% of all interventions identified across all 5 areas were classified in this way. The second most common type of intervention identified was classified as signposting, information referral and advice services. The third most common type of intervention identified was classified as peer support and mentoring. Then education, training and workshops to expand skill sets. Then education, training and workshops for mental health awareness, prevention and recovery. And then policies, strategies, funding and networks. The type of interventions that were the least common across all 5 areas were promoting physical activity, advocacy and legal support, practical help and assistance, prevention of further decline in mental illness, food security interventions, and finally, animal and green or blue space interventions. The majority of interventions across all 5 areas consisted of more than one type of intervention and aimed to address more than one risk factor. Although most interventions targeted all residents in the particular area, Many were designed to target subpopulations. The most common type of targeted subpopulations were older adults, people from minority ethnic backgrounds, women, men, carers, and LGBTQ people. The findings of this mapping exercise reveal that a wide range of projects that aim to improve public mental health are being delivered in local areas across England. However, this mapping exercise has demonstrated that across the 5 areas, the provision of services on the ground tend to focus on only a small number of risk and protective factors of public mental health. For instance, the majority of identified interventions aimed to prevent social isolation and loneliness by offering social activities and befriending interventions to local residents. Now, we had initially aimed to explore models of good practice across selected areas. However, we were unable to consistently collect information relating to evaluation, funding, programme numbers, and how long interventions had been running. This may be due to the complexities involved with the evaluation of community interventions. Charities are often project-based, meaning that they may receive short-term funding from more than one source for each project they run, each pot of money being ring-fenced to a specific piece of work within a project for a limited time. This results in a complex web of funding streams which begin and end at different stages within the life of the project. The implications of this is that it's difficult to produce in-depth evaluations. COVID-19. This mapping exercise took place before the COVID-19 pandemic took hold. It is likely that many of the interventions identified in the study were very limited by lockdown measures and even now will still not be back to normal. This is especially concerning as it is clear that community interventions play a part in tackling factors which have been made worse by the pandemic, i.e. financial difficulties, unemployment, social isolation and loneliness, and sedentary lifestyles. Therefore, next steps should focus on how to support such interventions through the COVID-19 era. Okay, so at this point we will move to the interactive portion of this session. We're really interested in your thoughts and comments on this work. So if anyone has a question, please feel free to put it in the chat box if you haven't already done so. Gillian Samuel, one of the peer researchers who worked on the study, and myself will try our best to answer your questions. If you wish, you can use this QR code to go to my Padlet board to start a discussion on what community interventions are being delivered near you or what you would like to see delivered in your local area. For those who do not wish to use the QR code, a link to my Padlet board can be found in the chat box.